Okay, good morning. Welcome. Can all of you hear me in the rooms? I hope you can all hear me. Thank
We can
you.
hear you.
Thank you. We can just get everybody to mute their microphones. And Stephen, as they enter the room, if we can get them to mute the microphones as we get new additions to the room. Good morning from the beautiful downtown Vancouver office. My name is Crystal Morris. I'm the Aboriginal Education Coordinator. And we are in Musqueam territory. I'd like to recognize the territory for which our downtown office resides. Today we are joined by Diane Smiley, who is going to do a presentation on trauma-informed practice. And just a little bit of housekeeping. We have a really big group today on video conference. You've heard me talk about the muting of the microphone. So how Diane is going to do her presentation is, if you have a question, if you can actually turn your mic on and get our attention, because what will happen is your video conference will be highlighted up in the left-hand corner. So just get our attention, and that would be the easiest way to do it with a group this size. In addition to that, actually, so there's 21 video conference units participating today. We have 60 plus Adobe Connect on the computer. So for those people who are on the computer, you're not actually interactive with us. You're not able to talk with us, but you're actually able to type your questions into the chat room. So if you could type your questions, and I will actually relay your questions. And if by chance we run out of time, what we're going to do is we will forward all the questions in the chat room to Diane. And in addition to that, we will get through as many questions as we can in this 2-hour period with the presentation. So what I'm going to do is turn the floor over to Diane, if she can just tell us a little bit about yourself and about the work that you're doing, and you can go right into your presentation.
Sure. Well, thank you very much, everybody, for joining this morning. It's just amazing to have so many people that are finding this a good presentation, to take some time out of your day to attend, and I appreciate how busy people can be, and know that finding this kind of time isn't easy. So I will say a little bit about myself and how I've come to be involved in this work in trauma-informed practice, and I guess speak more about my work experience for now. Starting early with some work in nursing, and then switching over to work in substance use services from a social work perspective. I think it was, always pretty easy and clear for me to see that, trauma was a big part of what was going on for people as I worked earlier on in my career as a clinician, and hearing people's stories and life experiences. And connecting that to how people were dealing with their mental health, what was happening for them in relationship to their substance use, and also their physical health and their spiritual health. Those things seem to all kind of fit together, quite a bit for me. And so it's always, for the last sort of 15 or so years, has been something that's been there for me in my work. And then I worked for a number of years in a treatment center for women who have problems with substances, and it also had programs for children and families, and had the chance to work in an agency where that kind of importance that trauma played for people was really taken into account. We really tried to take that into account in all of the services that we were trying to offer. So again, just kind of reinforcing that and seeing that it seemed to connect as well for clients that we were working with. And then a couple of years ago, I moved from Ontario to BC, and I've had the opportunity in the last couple of years to be involved in a provincial project for mental health and substance use services with the goal of kind of strengthening trauma-informed practice. And so that's been an incredible opportunity for me to be able to talk with other people that are thinking about this and doing work in this area, that are trying to find ways of bringing this to their work every day and to their programs. And as well, I've had the chance to spend a lot of time reading and thinking about this work from many different perspectives as well. And so, and in this, as part of this project, we've developed a trauma-informed practice guide, and we've been able to do that in consultation with many people from around the province. And there's an organizational checklist that goes along with that, and we're just in the process as well of developing a 2-day curriculum that's it's meant for mental health and substance use service providers, but could be probably relevant and adapted for lots of different people that are working in in related fields. So I'm going to draw, quite heavily on that work and that experience. I hope that it will be relevant for the work that people are doing, and I really expect that people will take whatever they do feel is relevant and use that to reflect on what it is they're doing in their own in their own communities, and help them figure out how they want to move forward with this. I don't think that I don't have all of the answers for everybody. Probably may raise even more questions for you, but I think that's part of this, is just doing some thinking together and trying to do some sharing of different perspectives on this. And I just want to acknowledge that I'm aware that in many communities in the next while, people will be communities will be participating or involved in truth and reconciliation hearings, and just recognize that the challenges that will bring for many people that are trying to do this kind of support work and thinking about trauma-informed practice as it relates to what's happening in their communities. And my hope that if there's a good one good thing that is happening, is that people are coming even more together to think about this, and think about how this can be an opportunity for healing, and to move towards even more strengthening community health, etc. But I'm not immersed in that work, and I certainly know and respect what your experiences and of what that means. And then just last thing before I kind of move into talking more specifically about trauma is just in general. I think people are all aware that trauma affects all of us in some way, and so anytime, even though today we're not going to talk in detail about any kind of specific trauma things, experiences, even just talking about the trauma and the effects of trauma can be a heavy topic. So I just want to invite people to kind of be aware of how they're responding to that, and feel free to take a deep breath if you think that might help at any time, or get up and stretch, or have a sip of water, or take a break and leave the room and come on back in. So just And I'm probably going to be doing the same. Well, I won't be leaving the room, but I might be taking a sip of water or stopping to take a deep breath. And do certainly invite people to ask questions, as Crystal had already said. So we can start. And actually, the first slide I've kind of already covered.
Of the PowerPoint. So this is what they're seeing on the computer. This is
It's just coming. Okay, so but the slides are going to come up, right?
Okay.
Take a deep breath if they want. Deep stretch. Here we are. Okay, so you can kind of move through, because I did just do that one with the background and everything on it, and now go to the next one. Okay. So I'm just gonna start by sharing some definitions of trauma, and I'm not meaning to be confusing by sharing more than one, but it is just coming from sort of this idea that there's a lot of different ways of kind of conceptualizing it or thinking about it, and from my perspective, they all have value. But I'm going to share a number of different definitions with people, and people can kind of think about which ones kind of resonate for them. But also, I'm trying also to share some things that will help you kind of know what, sort of what is some of the sort of more medical terminology, et cetera, as well. So the first definition that you're seeing up there is one that was used in a big study in the U.S. Where they did try, and it had a number of different arms to this study, where they tried to really integrate trauma-informed practice across some services for women that had mental health and substance use issues, and it's called the Women's Co-occurring Disorders and Violence Study. So they defined it as experiencing, witnessing, or being threatened with an event or events that involve serious injury, a threat to the physical integrity of oneself or others, or possible death. And the responses to these events include intense fear, helplessness, and/or horror. And then in another research project in Ontario, looking at the effects of trauma on women of childbearing age, they defined it a little more broadly, so that taking into account some more systemic kinds of issues that are related to trauma. So they're talking about interpersonal trauma as being defined as an experience involving a disruption in trusted relationships as a result of violence, abuse, war, or other forms of political oppression, or forced uprooting and dislocation from one's family, community, heritage, and/or culture. And then Stephanie Covington, who's done a lot of work in women's substance use services, so more of a sort of a feminist kind of lens, talks about it. And I like this one because she does try and help us figure out, okay, so how does post-traumatic stress disorder, or PTSD, how does that kind of fit within these broader definitions? So she talks about it as being, violence, trauma, and abuse, and post-traumatic stress are often used interchangeably. And one way to clarify these terms is to think of trauma as a response to violence or some other overwhelming negative experience. And that it's both an event and a particular response to an event. And the response is one of overwhelming fear, helplessness, or horror. And then that PTSD is one type of disorder, if you want to use that terminology, or response. Some people like to say response that results from trauma. And then So this is, in talking about historical trauma, which of course is relevant for Aboriginal people. And I've got the way it's been defined by two Indigenous scholars. They're both American. Dr. Maria Yellowhorse Braveheart talks about it as being the cumulative emotional and psychological wounding across generations, including the lifespan, which emanates from massive group trauma. And then Karina Walters talks about it as an event or a set of events that are perpetrated on a group of people who share a specific group identity. Involves genocidal or ethnocidal intent, and individually each event is profoundly traumatic, but taken together they can constitute a history of sustained cultural disruption and destruction. And when cumulative historical trauma events are coupled with the high rates of contemporary lifetime trauma and interpersonal violence, as well as high rates of chronic stressors such as daily discriminatory events, together these historical and contemporary events undermine physical, spiritual, psychological health and well-being in very complex and multifaceted ways. So it's a bit long-winded, and I apologize for that, but I think that one of the important things that I see that she's including there is that it's also that it's talking about how it's complicated by ongoing kinds of things like racism or things that discrimination that people have to deal with on a regular basis. Catch up to my. And I hear people using intergenerational trauma and historical trauma, to mean the same thing. And again, you do see lots of ways that both are defined. But I always think about historical trauma as being more of sort of a description of what happens, and that intergenerational trauma as being more of one of the many, many effects, right? So. But that being, and this was a definition from the Aboriginal Healing Foundation, talking about the effects of trauma that are not resolved in one generation. So when it's not resolved and it's ignored, and there's not necessarily or has not been any support for dealing with it, then it can be passed from one generation to the next. So the things that that people in a traumatic context have come to see as normal can be things that then they pass on to their own children and in their next generation in their communities, and that these unhealthy ways that people have tried to cope to protect themselves can be then passed on to children, and sometimes we're not even aware of how we're doing that. So now this is, a whole different, back to sort of a very biomedical way, but I think it's, again, we hear this term PTSD and post-traumatic stress disorder all the time. This is sort of the basic criteria in the diagnostical and statistical manual of mental disorders. That's what the DSM is. Really it's meant to be a classification system used for people that are in the field of psychology or psychiatry to try and be kind of consistent when they're making diagnoses. But certainly so it's supposed to help, kind of understand, for them to understand what it is, what kinds of symptoms people are experiencing. So, but it's much more an individually focused kind of framework. But it does give you a sense of, on an individual basis, what are the types of things that people could be experiencing, and when somebody gets a diagnosis, is diagnosed with it, this is, these are the criteria here. So. First of all, having experienced or witnessed a traumatic event, and then having either intrusive, memories or recollection, or else re-experiencing things. So, the kinds of things you'd hear about are nightmares and flashbacks. And then also people coping or responding as well over time by trying to avoid anything related to the trauma, or by having sort of an automatic kind of numbing response that just happens. It becomes kind of conditioned over time, or being hyper aroused or hyper vigilant, always kind of looking for, being ready to respond to something that's, like danger. And this is all related to sort of a fight or flight response. And that these things are, if they're going to make the criteria go for more than a month, and really interfere with daily functioning. So that's not to say that if you're not meeting person's not meeting these criteria, that they're not affected by trauma. And I think that's what's helpful, to have some of those real broader kinds of definitions as well. So I just, we're just take a breath maybe, and if I don't know if people have any questions or any thoughts about all the definitions, or what resonates for them or not, or what comes up for them in hearing all of those things, different definitions. Okay.
I have a question.
Okay.
So somebody who is very depressed, would that possibly be PTSD?
It could be, and for sure, and that it could be that somebody is has PTSD and they're depressed. I mean, for sure they are linked, and there's higher rates of depression and anxiety among people that have a history of trauma. It doesn't necessarily mean that they will be, diagnosed as PTSD, and I don't even know if that's for sure, how important that is. It depends on the individual and what they, which routes make most sense for them in healing, but you can definitely be. There is definitely a higher chance of being depressed. Is any other questions?
We do have a technical question on here. When will this presentation be available on the UBC Learning Circle website? So people are actually really interested in this type of information, probably information sharing, and that is one of the purposes of the UBC Learning Circle. So we're hoping to have a 2 to 3 week turnaround time. It's just that we've been so busy through April and May that we will work our best to get it onto our website in the next 3 weeks. Our technical support are listening at Health Canada, and Catherine is in the room here. So we will do our best to try and have it on in the next 3 weeks.
Okay. Okay, so I guess I'll go on. Is there, I can't.
Sorry. Okay, so I'll read another question. Louise is asking, can you clarify the difference between the historical trauma and generational trauma from the previous slides?
Okay, and really the two terms do get used interchangeably sometimes. So I'm just going to tell you how I've kind of made sense of them. So historic trauma, I just think about that as the like the process of colonization and things like residential school and Indian hospitals and all of those kinds of things that contributed to historic trauma among Aboriginal people, and then intergenerational trauma. The way I've come to kind of understand it is that it is one of the many things that can happen as a result of those things, where maybe an example would be somebody that went to residential school and didn't have an opportunity to learn, very much about parenting, and had a very traumatic experience because of it. So then they are becomes part of what's happening in the home when they're raising their own children, if they haven't had a chance to kind of work through that and kind of relearn some of the skills that were kind of taken away from them. So does that make it more clear? So I'm gonna now start talking about some trauma-informed practice principles, because we and also just define a little bit what we're meaning by trauma-informed practice. So maybe I'll do that first. So another thing that I think gets used, terms that get used quite interchangeably are and are defined in different ways: trauma-informed practice and trauma-specific practice. So I'm going to try and differentiate a little bit about them. And again, this is just the way that I've been working with them in the project that I've been involved in and how they've been framed for that. It's not the only way. So trauma-informed services are they're more how we think about trauma and how it affects all the people that we're working, many of the people that we're working with, and then what we do about that in our services. So like how we are embedding these kinds of what we know about trauma and how it may affect people. We're embedding that understanding into all of our work. It doesn't necessarily even mean that we're asking people about trauma or that we're expecting that people will talk about it, but that we'll just know. And that because of that, we're going to place priority on people's safety and choice and control, because we're recognizing that those things may have been taken away at different times in their experience. So we want to try and maximize that so it feels more safe and that people are able to kind of engage better in their in whatever kind of health treatment or other types of health services that they might be trying to access. And that we're creating a treatment culture of non-violence and learning and collaboration, sort of within our, and that may be treatment. I think that's from mental health or substance use services, but can broaden out to any kind of health service. And we're talking about being collaborative with our, people we're working with, our colleagues at work, but also the clients or patients that we're working with. And that's kind of in contrast to trauma-specific services that directly address the impact of trauma. These are important as well, but they're a bit different. So that they're the ones that are really directly facilitating recovery and healing, where people will mostly be talking about their traumatic experiences and how that's affected their lives. And here's just a little. This is a table. This is taken from the trauma-informed practice guide that will be released pretty soon. And sort of comparing what's trauma-informed services to trauma-specific services. Built in, one of the things that's interesting about this is that you could have a trauma-specific service, like a trauma treatment program. It may not be trauma-informed. It's a bit of an irony, so that you could be, sometimes if you think about some of the hoops or things that people have to say or, through our assessment processes, et cetera, that if they're not culturally safe or if they're, asking people to disclose information and not have the right supports, or it could be re-traumatizing even just to try and get to your trauma-specific service. It's just a bit of a contrast between the two. So today I'm going to talk more about the trauma-informed. Okay?
Let me know if I'm rushing.
No. Okay. So in the project that I've been involved in, we have looked a lot at, there's quite a bit of literature on, what would the principles be for trauma-informed practice, and we came up, and also did consultation with, quite a few stakeholders in BC, and so we came up with 4 key principles. And we feel like the principles are kind of a way to start with this, because we do know that we're wanting to make this, relevant to a wide range of types of health services and settings and communities, etc. So rather than try and say, here's exactly what you do, we thought, it might be more helpful to try and offer up, here's some principles that you can take or not take, but you can think about whether they can apply in your context. So the first one is just trauma awareness. So this idea that we before we can think about being really trauma informed, we have to be kind of trauma aware. We have to know things like, well, that the prevalence of trauma, is quite high, that many of the people we're working with are likely have trauma, that we be thinking about what is the impact of trauma, how significant that can be in terms of how somebody is functioning or how they've developed. And that there's a real wide range of adaptations that people can make or do make to cope and survive. And that also it's connected as well, and how it's kind of connected to issues like substance use, but also physical health, and of course mental health concerns, and could add in there spiritual health, etc. So we can go to the next one. And then the next key principle is emphasis on safety and trustworthiness. So if we can be just thinking about in all of our work and all of our services how because we may be working with people who have experienced things like boundary violations or been in situations where power has been badly abused, what does that mean in terms of trying to create places and connections with people that feel both physically and emotionally safe? And then the other piece in here that's important is to think about, and that people might even be in currently unsafe situations. And I think I said before, we don't really say, we're not saying that people need to be asked or people need to disclose that those things are need to be in people's control when they talk about and what they talk about. We do still really encourage people to ask about current safety, whether it be in relationship to being suicidal or if they could be in violent situations, that we would still encourage people to ask about those things. And it's part of this idea of safety and trustworthiness. So, we can talk more about this in a little while, but some of the types of things that you might try and do if you were trying to create services where there is an emphasis on these things is you'd be thinking about, how welcoming are our services, what's our physical space like even, I don't know, certainly have been in lots of different places where people are coming in and the first thing they're doing is talking through a plexiglass to a receptionist because somehow it's not supposed to be safe for the staff, and so there's that division, and some of those things can really be triggering, but also they don't feel welcoming. And then as much as possible, this idea of providing very clear information, being very transparent about what's going to happen or how the service is going to work, giving people time to ask questions about that, making sure that there's that there is real informed consent, that we take that seriously, because that's helps people build their trust and feel safer when they know it's not just just here quickly sign this, and also the idea of creating crisis plans with people. So if people don't seem safe, or if they are seem to be having some kind of a trauma response, feeling triggered, or they've disclosed something that might be a big deal the first time they might have talked about something, that you're kind of working right away with them on. So how you could be safe when you go home, or who's going to be there, or working with them to come up with something. And then, really important, and this has got to be woven through all the way, is, culturally competent care and culturally safe care, because you can't really have trauma-informed care if it's not culturally competent or culturally safe. Can go to the next one. And so then we're still in thinking about emphasis on safety and trustworthiness. This also applies to service providers, to all of us that are also working to try and do this, to try and provide these supports. That we need to be in good shape to do it, and we need to try and do what we can to create environments that are that are healthy, and that where we're going to feel safe as well. And then the third principle here is an opportunity for choice, collaboration, and connection. So again, it's just the idea that we're going to do what we can to foster people's sense of efficacy and self-determination and dignity and personal control wherever possible. And so we can do that by being, taking a real collaborative approach with people, being really transparent about how things work, communicating openly, really trying as much as possible to equalize any kind of power imbalances that, could exist, because if you're working as a professional and somebody's seeking help, they could feel pretty vulnerable. And that people, as much as possible, are able to express their feelings without feeling like they're going to be judged. And that people are offered options about how they want, what kinds of treatment they can have access to. That there's a lot of different ways that people go about healing, and that we're kind of offering as many choices as we can, and letting people really kind of be the ones that are kind of driving that process for themselves. Okay. And then the last key principle is being strength-based and skill building. So, working with people to help them identify their strengths. We think about there's lots of research on the importance of culture and identity and how it relates to resiliency. So to be thinking about those things. And then working to find ways both to teach, be aware of for yourself in your work, but also to teach people whatever skills that might be helpful for them to be able to sort of stay present in the moment, and to stay grounded, and to manage any kinds of trauma responses or triggers that they may have. And then also this one applies also to organizational culture, that we're kind of trying to promote within our organizations kind of emotional intelligence and social learning, ways of working with each other, and then maintaining competency-based skills, knowledge, and values that are all kind of trauma-informed. So just so that's those are the key principles that we've been working with. Can I just does anyone have any questions?
Somebody is typing. I'm not sure if there's anything.
What do you mean by the last one there? Maintain competency-based skills and knowledge and values that are trauma-informed. Does that go back to what you were talking around, or is that the actual around cultural safety, or is that competency as around the skill set to manage someone with trauma? So actually having the skill set around questioning, around facilitating dialogue, around creating safety.
I think it is like the competencies of being trauma informed, I guess. So probably all of the things that we've just talked about, and being able to sort of learn what you need to know to be able to do that, and understand values, etc., that are behind that.
Yeah, do you want to pop to that to see if there's any questions? We do have another question here on Adobe Connect, Can you explain more in detail the emotional intelligence and social learning?
Mm-hmm. So I'm going to come back to that at the end. It's based on some organizational work by somebody named Sandra Bloom, who is working. She's developed something called the sanctuary model, and it talks a lot. Those are only two parts of it, so we'll come back to it at the end. But I think it has a lot to do with being self-aware. And being accepting of how your colleagues are managing and trying to promote kind of organizational cultures where those things are valued, that there's lots of opportunity to keep learning. We don't have to pretend that we know everything. We're able to be vulnerable, and we're kind of asking in a way often for the people that we're working with to be doing those things. So, the idea is that we be living in a, sort of a culture, an organization, working in an organizational culture where we're also kind of walking that walk. And that would look lots of different ways depending on the organization. Okay.
Crystal, can you just ask Steve help for the PowerPoint back up? Because I can't see it.
Steve? Texting him too. Steven,
Yes.
can you put the PowerPoint back up, please?
Sure.
Can you help us? Thank you. I was just texting him.
Okay. So any other questions? Next. Oh, I think we did these ones, so we're all right. We should be going to the slide. Yep, there we go. So now, since our first principle was trauma awareness, and part of that is thinking about prevalence, and we could go on citing statistics, and I'm not going to spend a lot of time doing that. I think we all know that. That trauma is a pervasive issue because of colonization and things like the residential school system. But I'll say a couple of things about statistics. I mean, one that is from a general population of Canadian people, 76.1%. Reported being exposed to at least one traumatic event in their lifetime, and 9.2%, so almost 10%, and there's a few other studies around, and it seems to be around that amount, met the criteria for PTSD. So it's prevalent just in the general, very prevalent in the general population. For women in treatment, this was at 5 Canadian treatment centers. 90% for substance use, or I guess it's for alcohol problems. 90% had indicated abuse-related trauma as a child or adult, and then 60% had indicated other forms of trauma, which is completely probably consistent, certainly with my experience, and mostly everybody that I've talked to that works in the substance use field. And then I don't know if people are familiar with the CEDAR project. Excuse me, sorry. What's happening? Sorry about that. So in a sample or a group of young Aboriginal people from Vancouver in the Prince George area, 48% reported these are young people that have problems with substances reported experiencing sexual abuse, and they think actually that was probably an underreporting, because if anybody said that they weren't sure or maybe or they didn't remember, they didn't count that in the 48%, and then And then just this one, the last one is just because I think it's good to kind of recognize this huge overlap with other types of mental health, what's considered more, serious mental health issues like schizophrenia and bipolar disorder. That in one study of 102 patients where they went and did kind of looked back to see how many of the people that had been diagnosed with that had a history of childhood trauma, almost 50% did. So there's, it makes you think that there's definitely some links there. This is a screening tool that was used in a project in Ontario for urban Aboriginal people living in Hamilton. And I thought it was just interesting because it doesn't actually ask about, trauma experiences. It sticks more to what what are the responses that people had, which I think is a less intrusive way of doing any kind of screening if you think that it's important to do. So that, people were asked, because, in your life, have you ever had any experiences that were so frightening, horrible, or upsetting that in the past month, you had nightmares when you thought about it, or thought about it when you did not want to, so that re-experiencing or intrusive part, and then tried hard not to think about it or went out of your way to avoid situations, were constantly on guard, watchful or easily startled, so it kind of relates to that hyperarousal, or felt numb or detached from other activities or your surroundings. And you can see here that that these were quite prevalent, and this is, don't forget, this is just in the last month. And in this screener, if you get 3 of them, if you're saying yes to 3 of those things, then the next step would to be have more of an assessment. It's not sort of a diagnostic thing at all, but you could see that 34% had. That they looked like it would be worthwhile to check to see if they had PTSD. So, just to say more about the effects of trauma, they can be often enduring, very profound, and can shape every aspect of a person's life, even years after the traumatic experience has occurred, and are particularly traumatic when the violence is something that is ongoing and that begins in childhood.
I think there was a trigger there.
Pardon?
I think it's a trigger there.
Okay. Begins in childhood and is perpetrated by someone the person loves and who they should be able to trust. So maybe it's a good time actually just to take a big stretch if you want to, or if people feel like going and getting a quick drink of water, or standing up or walking around. And also if you have any questions as well, be a good time to ask them. Yes.
With all the history of abuse and trauma in people's pasts that link to it, how do you feel about gender-specific treatment centers and gender-specific groups for women? Because we often do mental health stuff all combined.
Yeah. And again, I don't like to be the, feeling like I'm prescriptive or telling people how people know what they need in their communities or whatever. But certainly, I have a big bias around that I think it can be better, for offering gender specific or gender responsive at least kind of programming, because women and men do have different needs. Certainly there's important community pieces and family pieces, and not to say that those are not important as well, But I think it's in that the principle of offering people choice and options, so that they're not having to go about this in just on taking one path.
Thank you. I think we could probably just carry on.
Yeah. Okay.
I don't have any knowledge of the technology, so.
Yeah. Okay.
Oh, do we need to go to the next slide? Okay. I think we'll just take
Yeah.
1 minute.
Yeah. We'll take a minute.
1 minute break.
Regroup.
Yeah.
Yeah.
I'm just going to do a quick one.
Yeah. So are we still? I'm still on though.
Yep, you're still
Okay.
on.
All right. Pardon? Yeah. Yeah.
I need to have my second person though, just to make sure.
Okay. So yeah, I mean, as I said before, please, this is quite a lot of information to have to kind of absorb all at once. And so again, feel if we want to just take a break, and if people want to just kind of check in with each other in the rooms, see how they're doing. And then we'll just come back in about a couple of minutes. We'll give everybody.
That's great.
Hello, I'm just calling from Hazelton. Is there any chance that the PowerPoint presentation can be made available?
Yes, it can.
Yes.
Yeah.
Yeah, it can.
Can you guys not see it?
We can put it on our website, right? Is that okay, Diane?
Yeah.
Yes.
Yeah, I'm just looking at the effects of trauma, very small print, and it would be nice to have this also just to be able to download it onto my own computer.
Hello.
Hi there.
Is it possible to improve on the Zoom? Ours is very fuzzy.
This is Port Hardy, and it's very fuzzy. I can't see anything except the headings.
Oh,
Same.
all the time. Is it just with this slide, or is it with all of them? Because this one is a bit
All
small.
of them.
Oh, really?
All of them.
Yeah. Oh, okay.
Unfortunately, due to the connection and the size of the text, this is as clear as it's going to get.
Good lesson. Okay.
And this is Port Hardy. It would have been helpful to have the PowerPoint slides prior to the presentation, and we could follow it.
There's nobody on video.
Do you usually send it out?
No.
Oh, okay.
Yeah, good for them.
Yeah, that's, I know I was struggling with this at home thinking, oh,
Yeah.
but okay.
Yeah.
So some
Okay.
questions? Okay. Okay,
Wow.
we're back. Hi, everybody. And did we have a question here?
Oh,
or-
it was just, it was about the screening tool. Is there
Oh,
a
okay.
screening tool, a very informal set of red flags for nurses or other healthcare providers to be aware of when considering referring a client to a counselor or other professional regarding trauma?
And so we were actually just having a conversation about that very thing in the room here, and so I think there's been a lot of discussion, that I'm aware of about, when is it a good idea to use a screening tool, and when is it okay just to make a referral based on how someone's functioning, or what are they, kind of what kinds of things are they struggling with. And in many cases, that knowing that trauma is often going to be a part of what's going on for people, but there's definitely sometimes that people would want to use a screening tool. So there is the one that I just showed you, and I was just suggesting here that there could be more discussion. This was a project in Hamilton that was for in Ontario, that was for urban Aboriginal people, and sort of they were in a community-based research program where they were partnering with a number of Aboriginal organizations to try and build some kind of data about what their people in the city were struggling with, or what were the health issues. So that was one part of it, and they used the screener that I showed you. And I like that screener because it doesn't it just asks about people's experiences, what's going on for them. It doesn't ask them to disclose anything. And it says the wording is a little better than some of the wording that I've seen on other ones. So, but it could make sense to talk with people in Ontario about how well that worked in that community there, and see whether it would be something to consider, or maybe there's other ones. There's another other one. There are definitely other ones, but there's none that come to mind as right now as ones that I would necessarily suggest. So people can't, maybe we'll just go back to that one slide quickly. So, and I know people can't see this very well. It's a table. It will be in the Trauma Informed Practice Guide that will be released in May. So hopefully people will be able to access that if they want. And it just shows that the effects of trauma can be in many different parts, many different sort of domains, if you will. And so, they can affect people physically and in a number of different ways. And emotionally, spiritually, and in interpersonal ways, how people are getting along or relating to others in their life, and then there can be behavioral ways that people have sort of usually coming from trying to cope with the effects of trauma. So things like substance use and other gambling issues, etc. And some of the things that will kind of influence how whether or not people will have lasting effects, so post-traumatic stress, and how severe it might be. So there's, it looks different for every person, and not everybody is necessarily affected by a traumatic experience. And certainly if they are not in the same way. So, but some of the things that influence are, so is how long does it go on for, if it's sequential, and if it's intentional, if it's life-threatening, if it causes physical injury. And there's been a lot of research in the area of combat, and so that and some of this feels pretty obvious, that if you're exposed to more combat, then you're more likely to have lasting effects. If you witness death, lose a loved one, and also sexual victimization is also linked to having more issues, more likely to have issues. And then one of the things that that was mentioned there is if it's starting early and it's ongoing. So we talk about developmental trauma as another term that people might hear that is more related to where it starts early and it's happening within a caregiving system. So the people that are supposed to be responsible for your safety are the ones that are involved in it, and then what happens is it affects ability to attach, and it can change the way people develop and children develop, so that they end up having to develop more in a way to protect themselves and to survive, and which means that they are not as able to engage in things like learning. And there is a whole sort of neurodevelopmental or kind of brain explanation for why this happens, which I'm not going to go into in detail today. It would be like a whole kind of presentation, but it is worth learning about. I think that it's not, and I think the other thing that is good to know when you're thinking about it is that at the same time there's been some there's been more and more research on how we can recover from these things, and that how even if it's had an effect on at a neurodevelopmental level, that it can be that can be shifted again, and that our that part of our that aspect of our health is something that can also improve. And I think there's going to be another learning circle that I'm very interested to attend that is going to look at some of that and talking about how there can be how some traditional knowledge or indigenous knowledge and practices can be applied to support people in healing from that kind of effects. And and there's some other research that has been going on specific to the effects in children, and this is sort of in the context of developing interventions to help children, linked again to more of a neurodevelopmental approach, but also here, recognizing that these are some of the types of effects that children and youth can be struggling with. So, different ways of conceptualizing these things. So, affective problems. So, pervasive kinds of sadness, fear, anxiety, anger. A big part of it is having problems with regulating moods, feeling kind of overwhelmed by moods, or it could also be depressive feelings. And then behavioral problems, which we've talked about in the context of other, of adults, but including, for substance use as a way of coping. And then cognitive problems, which can also be kind of distorted ideas about why things happen, and that's why with children it's important to kind of try and understand, know that they may because they had to be able to survive and continue to have connections with their caregivers, they may have kind of have some distorted ideas about what's right and what's not right, and whether or not they've been treated well. So all of these things can be, reduced. So we've talked a lot about what can increase the risks and what are the types of effects. I think also important to talk about how you can reduce the risk and severity of lasting effects. So, and that's kind of, again, where sort of some of the trauma-informed principles are rooted in this kind of thing. So it's like when there's acceptance, when we're not doing any blaming at all, and when it's not, when it's not stigmatized. So the problems that people are having are not again, sort of they're not feeling stigmatized again because of them, because that's just, of course, makes it worse. So acceptance helps reduce how severe they are. When there's care and nurturing from loved ones and community, that also helps. And when there's the availability of supports and helpers to help people with the effects of trauma. So, there we are. So, in terms of what you might see as a service provider, for people that have had more severe experiences of especially of starting at childhood abuse and neglect, you could see a whole array of issues, and many service providers and sometimes as well survivors themselves can misunderstand these difficulties as being self-inflicted, because they don't understand how the abuse or trauma has affected them so deeply and how it can reverberate through their life. And that's a quote from Laurie Haskell, but I think it really is something for anyone that's trying to, in that support role, to kind of remember. So just I'm going to say a little bit about the connections or the interconnections of trauma, mental health, and substance use. So this is another very well-known study. The Adverse Childhood Experiences Study. It gets referred to all the time as the ACE study, and this study actually took place in San Diego, and it was about 13,000 people participated in it. It was all people that had health insurance, so that would suggest that it was more of a middle class kind of population of people in the U.S. And people were a little bit shocked to find out that, and I'm just going to flip to my notes on this because it's a little bit more than I'm going to remember exactly right now. There we go. Oh, here it is. So over half of the respondents reported at least one adverse childhood experience, and the adverse childhood experiences were things like emotional abuse, physical abuse, sexual abuse, emotional neglect, physical neglect, witnessing domestic violence, grew up in a household where there was substance use problems, or mental health issues, where parents had been separated or divorced, or where there was one person that was one member of the family that was in jail. So they found that over half reported at least one of those things, and a quarter reported two or more. And they also found that people who had experienced 4 or more of those were 12 times more likely to have increased health risks. So problems with alcohol, substance use. Somebody mentioned depression earlier. That was one of them. And 2 to 4 times more like, suicide was also 12 times more likely to have be suicidal. 2 to 4 times more likely to smoke or have rate themselves as having poor health. And then even there was also a link that was made between the number of adverse childhood experiences people had and the number of adult health issues they had, so such as heart disease and diabetes and chronic lung disease. And the people that were involved in that study developed, this is a very well-known sort of diagram that kind of they've tried to show this trajectory that so if it's not, it's a potential trajectory that doesn't, if it's not kind of interrupted, right? So lots of hopefully opportunities to shift what can happen. But it's starting with, so on the bottom layer, you're seeing the adverse childhood experiences that are then connected up to, problems, developmental trauma, as we talked about. They're calling it disrupted neurodevelopment, which then lead to a range of social and emotional and cognitive issues. And then if those things aren't, identified and people are not getting support for them, it of course can move into some other, more risky health things. So, smoking and substance use, which then, increases, the chances that somebody will have other chronic diseases. And this one, I'm sure you probably can't see this, because if you're already having trouble seeing, it's really just a graph that's showing how the increased risk that people have of certain types of health issues. And the biggest long bar there is suicide attempts, and then the other ones are alcohol and drug abuse and depression are the next biggest ones. So I've kind of already, and then you're seeing still an increased risk of the bottom part, or the shorter bars are a range of different kinds of physical health issues. So it's just, it's just a study that sort of really established that there are links, between trauma and all kinds of health issues that people have. And so while we're talking about, making links, and so we've already kind of talked about, how substance use and mental health and violence and trauma are kind of overlapping, or we talk about intersecting issues. There's all kinds of other things, contextual kinds of things that are also, linked to trauma and to how it affects people. So, and I don't know how well people can see that, but you're seeing, there's other kinds of systemic discrimination, or else things like, resilience, and then we see colonization on there as well. And racial discrimination. So there's a whole, kind of range of things that will shape and are intersecting. And just, because in my work at BC Centre of Excellence for Women's Health, we talk another area of work that people are involved in is, sort of looking at FASD from a sort of a women's health perspective. And again, you kind of see these overlapping things, right? So violence and health issues. And so this was a study of the birth mothers of people that had fetal alcohol syndrome, and 80 women were participated in in-depth interviews, and 100% reported being seriously sexually, physically, or emotionally abused, and 80% had unaddressed health issues, and 80% were living with men who did not want them to quit drinking. So you can sort of see that there's all these different overlaps. Does anyone have any questions?
Because we have to wait for people to.
Okay.
I just have that sound is muffled, and that's it.
Oh, really?
Okay. Again.
Hello?
Hi.
Hello? On that pyramid, what did the one that was second from the top say?
Okay, I'm just going to put a microphone on here too, because people are having a little trouble hearing me. So the second one from the top, I believe, I'm just going to flip back here, but I think it's like a chronic health issues one. Yeah, it's chronic diseases and social problems.
Oh, okay, thank you. And then the top one is death? Early
Yes,
death?
early death, yeah.
Okay, thank you.
So I'm just going to share some examples of how what trauma-informed practice can look like in different contexts, and certainly, happy also to hear, what other people have in their experiences, what, kinds of trauma-informed things they are already doing. Some of the things that, in terms of trauma-informed practice is when you're applying it to take into consideration this understanding that the role of violence and trauma play in the lives of most people that are accessing our services. I talked more about mental health and substance use services, but I think it really applies as well to many health services, that we're kind of trying to integrate that knowledge into all aspects of our services. And that we're trying to, including, providing support to survivors to manage their responses, and so that they can actually be able to participate in whatever it is that we're trying to offer. And that means that we kind of go beyond just trying to accommodate people and accommodate for trauma, but we're actually, trying to go out of our way to reach out and figure out how do we make this work for people if they do have a history of trauma. And one of the ways that people have talked about it when I was talking with people across the province was just that it was a bit of sort of a culture shift, right? It was, this move away from thinking about, what is wrong with somebody, to more of sort of what has that person's life experience been or what has happened. And that can be translated or can be reflected in maybe different kinds of language that we use. And you can sort of see, here's a list of ways that people have sometimes described people who are have been seeking help or trying to access or help. And certainly I heard other things too about the idea of not just making a person into a diagnosis, that it's a whole person, that maybe they have part of what's going on for them is they have a mental health issue. I've also heard people talk about shifts in language they already made years ago. One of the ones that always stands out for me is working in substance use programming, and in some cases where people were providing, doing urinalysis, and where would have nurses saying that it was dirty, and sort of, thank goodness, many years ago started to shift away from that, using that kind of language, and in many cases not doing things like urinalysis, but other types of things like calling people, controlling or paranoid or just non-compliant, etc. So there's lots of and when I talked, I know a couple of places where I was, people really took this to heart and were actually worked in their teams to try to, and gave each other kind of permission to call, to debrief on it, or to say, hey, if you hear me using language that you think might kind of be reinforcing stigma, then let me know. So we heard about a team where that was quite an effective thing to do. I mean, it'd have to be a certain amount of trust, but within the team. But I thought it was an interesting way of trying to start working on some of this. One of the biggest, places where this kind of really hits the rubber, so to speak, is right at the beginning of services, any kind of services, because it's that idea that if we're not able to be trauma informed in the way that we're, asking people to enter into our services, then they're not going to get there. So it doesn't really matter what you have, if you've got a wonderful program or if you've got wonderful health care, if people don't want to go, or they are asked things that make them so uncomfortable that they don't go or they don't come back, then it defeats all of that. So some of the things that people talked about when we were doing our consults across the province were, again, that thinking about how can we create safety right at the get-go as soon as people are trying to access service, and how that had to include cultural safety, how to prioritize kind of things that would be engaging for people that are going to kind of begin to establish a therapeutic relationship. That you're going to not be, sort of pressing for compliance. And there's a real tension often for us, right? Because we do have to collect certain kinds of information, and also to be able to do good care, we want to be able to do the right kind of assessment. But it is a bit of a balancing act, right? So that we're not going to lose somebody, that they're not going to come back just so that we get all of our paperwork done really quickly. So people talked about ways that they tried to slow that process down, or how they made parts of it, less formal so that people would feel more comfortable. And they'd let people tell their story in their own way, in their own time, and then they might go back and ask questions that they needed to. And then also the importance, and I mentioned this before, of screening for present concern. So as much as we don't necessarily need to push to get people to talk about whether they have a trauma history or not, we do want to do what we can to make sure people are currently in safe situations. It's also, people talked about, the relief that their clients experienced when they tried to normalize what they were going through. So when people feeling, upset or sort of blaming themselves for some of the things that have happened to them, or the things that they're experiencing as a result of trauma, to try and sort of, it's that whole piece about a normal response to an abnormal kind of situation, and that, even saying things like that's shared, other people have those kinds of experiences as well, can be an enormous relief for a lot of people. And being able as well to set boundaries with people, like feel okay about being clear in a compassionate way. And setting boundaries isn't about being, sort of rigid and never flexible, but it's also just being clear about how you're going to be able to best help someone and let them know what that's going to be like, so that they know, and that can create some safety as well. And then they won't feel hurt at some point if you're saying, no, I can't. That's not, that's sort of going beyond, what I'm really able to do. And certainly realize that can be a particularly important thing in small communities where people are asked. It's harder because you're working with potentially neighbors and family members, certainly people that you may have known for years in your community. And then, rather than focus on what are the traumatic experiences that people have had, when you're working at sort of at the trauma-informed end of the continuum, it's more just being, identifying what are the symptoms or responses that people might be experiencing. You can say those might be linked to difficult things that have happened in the past, but you don't need to be asking people necessarily what they were. And there's a number of different sort of guides and guidelines that have been recently published. One, actually, I think it says 2003 down there, but that's a typo. It's 2013 for this one, Gender Matters, has just been published in Ontario. So, some of the things that all of them talk about are, this idea of providing very clear and practical information at initial contacts and giving people as many choices as possible. How do you want to be contacted? Why am I doing this? Like, if I need to ask you these questions to explain, why we do, and try and be giving people as much, in the way of options about how and when, and definitely, pausing and letting people ask questions. And if you're seeing people responding in some kind of distress, to do what you can to be supportive. So, and this is Peter Menzies, who's a social worker in Ontario as well, and he wrote a chapter in a book. So there's many, this is, we could all get together and write a lot more on this probably. But these are just to kind of stimulate a bit of discussion, and people have things that they want to say here. I'd be really interested in hearing. But, we talked about cultural safety. One of the things that Peter talked about is recognizing the diversity, right? And then how we're all, different in our history, and certainly in our identity and our culture. And I guess an important part of that is, that not all of us have had access to lots of parts of our culture, or at least it's not necessarily in our awareness that we've had access to it. And so that, not expecting that people will know, more, because they may not know, and so sort of being accepting of that. And that depending on where you're situated, what kind of service you're in, that know that there's lots of good reasons why people don't trust going to any kind of health care. Again, it's linking back to colonization and negative experiences people have had, things like Indian hospitals, etc., can really interfere with that. So just being okay with things to take a bit longer to kind of develop that kind of trust. And then Peter also talks about being prepared to offer clients sort of a larger social contact. So, that linking to things like residential school. I mean, we think that we all are, I think we get immersed in it and think that everybody is aware of that. But, just the other day, I had somebody telling me that, a cousin that had no idea that, how terrible that whole system was and how damaging it was. So that if you don't, if people aren't understanding that, then, it's sort of left to be thinking about it through a negative, only seeing the negative effects of that, and not, kind of understanding, well, how could that have happened to our people? And then, really important as well, recognizing the value of traditional knowledge and cultural and spiritual practices as well. And where possible, help or partnering with elders or helpers or whoever the teachers are in your community to help make sure people have access to those things and that it's recognized as being valid. So even though sort of the starting point of people don't have to disclose trauma to be offered trauma-informed service, it can still be that you're acknowledging the common connections between things like substance use, mental health, physical health, and trauma. And also when you're working with people that you can recognize, with them, the range of different responses that people can have And I guess, I might want to make a caveat that we can't necessarily attribute everything, because there's other things going on, could be going on, and certainly, colleagues working in, doing FASD work, et cetera, remind often that many of the same kinds of things could be, related to FASD. So, but it still, you can help people make some of those links in a general way. You don't have to say this is what happened to you and that's why this is happening, but you can, in a general way, say these are the kinds of things that can happen or that people do experience. And then just recognizing that trusting relationships can be difficult. And if you do see somebody that is is looking triggered or seeming triggered, to try and provide some support. Okay. So on that note, if people are trying to think of, what are the kinds of things that you might see in a moment if somebody was having a trauma response. So you can see a whole range of things, and of course they might be caused by something else, but it's part of what you can be thinking about. So just even being kind of sweaty, if you see people changing their pattern of breathing, sort of holding their breath, or starting to breathe quickly, if they're looking kind of stiff, or having difficulty relaxing. I'm kind of chuckling because I'm thinking all of a sudden aware of myself, kind of all hunched over here. If you see people kind of being flooded with emotions, it could be rapid heart rate, it's more easily startled, shaking, being disconnected or numb, staring off into the distance, and having trouble concentrating or even difficulty speaking. And there has been more and more work also at looking at how the physical environment affects how people are kind of able to engage in services. And we touched on that before, and I mentioned that whole, trying to talk through a plexiglass. But people have kind of gone beyond that and even been thinking about, what kind of signs do we have up here? Like, how often do you go into some kind of a service and there's a lot of signs telling you what not to do? I've certainly seen that in quite a number of treatment programs. So if you're thinking about how does that, if you want to make people feel welcome, that might be one thing to consider. Thinking about where are people waiting? Is that comfortable and inviting? Are things like even lighting outside, is it safe in that way? So if people are trying to access or having to come to a service after dark, are they having to walk through somewhere dark, a dark area where they feel, unsafe? And how accessible are things like washrooms? And you can do, even in your counseling room, one of the things that you could, give people the option of where do they want to sit, or would they prefer to have the door open or closed. Does anyone have any examples? Because I'm kind of, these are just, meant to be kind of snapshot ideas. I don't know if people that are there have examples of how they've already been trying to incorporate this into their own work.
Hello, it's Port Hardy. Can you hear me?
Hi. Yes.
I'm currently doing a research in the inner city environment in Vancouver, and I can certainly relate to a lot of these effects of First Nations and Métis people attempting to access health services in the mainstream. And I see a lot of these responses and how they react, and descriptions of their feelings, and how more comfortable places can be, or more welcoming, acknowledging, and so this is awesome. And I could just see nurses using this, and part of a curriculum for nursing social work. It's awesome.
Great. Well, that's good to hear that it feels relevant, and that not as good to hear that that's what people are experiencing in Vancouver. But I hope that some of this gets to be, is something that people are thinking more and more about, so that it will be better. Some of the other things that, just in terms of thinking about, counseling or working directly with people, and these are things that I see, even in what I would think about as being really good quality kind of community-based services. Sometimes, still where we could really improve on being consistent with people and follow through. If you say you're going to do something for somebody, to really try and make sure that happens. I mean, I can think of a couple of terrible examples in my own work, and I'm sure others can as well, where you're trying to make a referral, or somebody finally gets the courage to go and talk to somebody about someone, or go to another service. And then somehow it just, you get there and it's just the person's not there, or it's not happening, and then that's it. That, the person is not going to, in a couple of cases that I'm thinking about anyways, that, did not try again for an awfully long time. So those are, I think, being as honest, and we keep saying these things, like being as honest and transparent about what's going on, even if you do, because of the type of program that you're offering, have to go through, sort of difficult, big, comprehensive assessments or something. It makes a big difference to explain to people, where this is coming from, to acknowledge the challenges that they are maybe experiencing as they go through it, and let them know that they always have they don't ever have to answer something that they don't feel comfortable answering. And some of those things can go a long way to making it easier and making it a more trauma-informed process.
Steve and Al at EHO, this is Catherine. Can you please just make sure the bridge goes past 12 o'clock today, just to be on the safe side?
Okay.
Thank you. It's programmed to go off at a certain time. So
Oh, okay.
make sure that,
All right. That doesn't happen.
just in case.
Okay. So
Take your time,
we'll move
but
along.
make sure we-
Okay. But I know everybody's counting on it being over soon too.
Yeah.
So we can go to the next slide. Just some ideas, and people, throw some out if you have some ideas as well. Wherever possible, think about how you can offer choice. It may be, where do you want to meet? Which, service provider do you want to see? How do you want me to contact you? What are your, this is probably more important, is what are your priorities? What are your goals? Making sure that those are the things that are kind of really at the core of any kind of work that you're doing with people or service you're providing. And just, asking permission sometimes to ask questions, again, can go a long way. Just a very little bit on, we talked about the principle of being strength-based and skill building. So, just a little bit about, thinking about what kinds of things this might be initially. In the very first one, finding out or thinking about what are, sort of what knowledge, traditional knowledge, or, what are the cultural approaches to healing that people might be relevant for people, but again, not assuming that they are relevant for everybody. And I mentioned that before. I'm going to talk about sort of other, kinds of coping skills that are sort of grounded in, different sort of different philosophies or in different cultures. So one of a very basic thing that can be useful is teaching people grounding skills. And I guess I'm saying teaching people, but I think, teaching ourselves as well to get good at these things, because we can all use them for sure. So there's different kinds of grounding, which is really just orienting yourself to, the present, and sort of, bringing yourself back into the present moment. And the better you get at that, the easier it is to kind of manage some of the effects that you might experience or people you're working with might experience. Lori Haskell, there's a book here. I've got a little clip up it, a picture of it up there. It's called First Stage Trauma. It's published by the Center for Addiction and Mental Health, and you could access it online. It will go into a lot of these things in a lot more detail. So different types of grounding, sensory, which could be drinking water, it could be spritzing your face, it could be doing something that has to do with your five senses, and cognitive types of grounding are more kind of you might try counting backwards, or you might look around and be aware of your physical environment, different parts of it. I see what you see around you. And self-soothing is more like self-talk. I'm going to I'll be okay, and I'm in a safe place right now, those kinds of things. Containment is another kind of skill, and that involves trying to just learn how to be able to take a break from what can feel like kind of a lot of overwhelming feelings or various kinds of effects. So it's a skill that can take a lot of work for people, and it can take some time. But there are certainly ways that you can do that, and actually there is some information on that in that book as well by Lori Haskell. And then two things that are getting a lot more attention in relationship to trauma in the last while are this idea of mindfulness, which has some similarities to grounding, but it's from the Buddhist kind of philosophy originally, but it's been used more and more in all kinds of health promoting ways, or as interventions in helping people with a whole range of health issues. And it's just the idea of developing an awareness of the present moment in a very kind of particular way. So it's paying attention in a very kind of particular way. And it is also a skill that, takes time to develop, but can be very powerful, and actually is, they're making links to how it can be very healing as well. And then self-compassion is also linked to mindfulness, but it's this idea of extending our self-compassion. I think this is a really useful one for anyone that's a service provider. In those instances of perceived inadequacy, or feeling, a perception of our failure and general suffering as sort of something that's common that we're all as humans kind of experience. So you can trying to be more compassionate with yourself, and the more you're able to do that, the more able to do that with people you're working with. Very briefly, just to touch on, because I think she made in the trauma world of sort of trauma theory, had made an important contribution, Judith Herman, and she talked a lot about the stages of recovery, and she broke them into three And I don't think these need to go in a sort of, they're not meant to be in linear, like 1, 2, 3. But one of the important things in here, the first one, safety and stabilization, is just the idea that it's often better if people can get those skills to try and stay stable and safe before they do any of the other remembrance and mourning kind of work. And that trauma-informed practice is definitely on that part of the, safety and stabilization kind of continuum. And later, people could engage in more of the other, in other things, but like remembrance and mourning, and then reconnection and integration, if they choose to, because in trauma-informed, we're going to the trauma-informed principles. People do those things in their own way, in their own time, and when they choose to. And when you're thinking about skill building with people, it could make a lot of sense to talk with them about what they've used. This idea of being strengths-based, and people often have come up with healthy ways already of coping. And the idea that different things work for different people. So, for example, where breathing can be a very powerful way of grounding for a lot of people. Take deep breathing. For some people, it's not. And for some people, it could even be triggering. But so it's okay, for people to choose not to do certain things, and to get to have some choice in which ones they want to try. The other thing to keep in mind is it takes a lot of practice to really be able to benefit fully from grounding. So people might find it a bit discouraging at first, and that it's better to try and do it early in your sense of feeling overwhelmed or uncomfortable. And a good idea to practice it when you're not feeling overwhelmed. But once your body has already kind of moved into a full response, it's harder to become grounded. Yes?
Maybe you could just talk a little bit about how this practice could help before and after the people come to TRC to tell their story, because there's going to be all those supports at TRC.
Oh, yeah?
There for the 4 days or the 2 days, but before and after, they're eligible for a counselor to come into their community. But what else could communities do to help people prepare? Because they're just going to go right into the remembrance and mourning.
Yeah.
And like I said, there's going to be lots of service
Yeah.
providers at the event, but not when they come home or before
Right.
they go.
Right. I mean, I guess the first thing I'd think about is, we talked before about making safety plans with people, and also talking with people about, what will this be like for them, and the kinds of things that they might expect, that it would be, normal for a lot of people to feel pretty triggered afterwards, or to have, more problems with their moods or nightmares, flashbacks, and the whole range of things. We don't know for sure, because it can be different for every person. So if people are, having time to learn more about things like grounding, but also, how when I go home, will I be safe? And is there a person I can call, or is there some person that can stay with me that night? And it's the whole piece around the, making a plan, and helping people think about before they go and do it, what it will be like.
Thank you for that. I'm just noticing the time,
Yeah.
and we only have a couple minutes
Yeah.
left, and I'm wondering if there's a way to give it your best shot, to kind of finalize where we're at. I know that we could go a little bit over, but I'm also aware that people have lunch.
Yeah, for sure.
And we could also come back and continue this at another session as well.
Yeah, I mean, I'm happy to. We're almost actually at the end, and I'm looking at what we have left to cover. And I think it would be it's probably more important to people have a quick opportunity to ask any more questions right now.
Awesome.
That they have, and then we can wrap it up.
Are there any questions out there? I'm looking online, and I'm also just looking to our people on video conference. And you'll notice there's a different voice. It's Leah here. Crystal had to step out, so I'm just finishing the session here for her.
One of the things that will be in the trauma-informed practice guide is a very big long list of online resources and other resources. So once that's been released, we can make sure that gets out to people. You're seeing an example of a couple of things. I'm sure people are aware that there's tons of resources on the Aboriginal Healing website, Foundation website. And there's these are two very neat community-based research projects. One was you could go online and actually listen to video clips of women talking about their own experiences and their as the children of people who had mums that went to residential school. And then Stilettos to Moccasins is a really neat project where women that were in conflict with the law developed a video, a workshop, and it's all about their own healing journey and sort of how they shifted in terms of their cultural identity, and then inspiration that they want to share for other women that may be having some of those struggles.
Do we want to do this right now?
Do people have questions, though? I mean, there's only a couple of slides here, and they're not, I don't think they're critical at this point. I think it would be, if people have any questions at all, I'd be happy just to answer those, and we'll see these when the PowerPoint's sent out to people.
I'd also like to invite people, if they have questions for Diane after that come up for you. We'll put this presentation on the Learning Circle website, but if there's things that come up, we can forward the questions that are on Adobe Connect as well as from you via email to Diane, and make sure that they get answered.
Yes, it's
Hi,
Diana.
Oh, sorry.
Hi. I have two questions. One is, what is your definition of cultural safety? Because, I mean, we speak of cultural safety, and a lot of health providers are not.
Did I lose you, or can you? I got the question, I think, most of it. So I guess I would just, I define cultural safety as, being aware of, what does that mean? I guess it's making sure that you're not bringing your own sort of cultural lens to your work with other people in a way that's going to alienate somebody or even re-traumatize them because they feel like somehow they're being, they don't belong, or their worldview is not welcome, or even unintentional kind of racism, that may come as, in the form of some assumptions or stereotypes or stigma. But do you want to share, do you have something in mind that you're thinking about that you want to share? We lose.
We can switch back to showing the video conference people if we're done with the slides.
Okay.
FaceTime. Except they lost the bridge.
They lost the bridge. That's what happened.
Oh, so it's all gone.
And so
Okay.
he said he was going to. I just called it too.
Oh,
There they are.
There they are. Hello.
Welcome back.
That's great. So you're on still, I think.
So I don't know if you heard me when I was defining cultural safety or providing a definition of it, but I'm certainly interested in hearing what yours is. If you and the end of your comment, I think you weren't quite finished asking your question. Oh, it's not. Okay.
I guess that's it for the.
I have one question. This is Trisha in Mount Currie.
Hi there, Patricia.
Hi.
Hi. I'm wondering when the guide to trauma-informed the trauma-informed practice guide will be available. You said May, but where will we be able to access it as well?
So we're having a web launch of it on May 30th, but it would be in circulation before then, and we're not totally sure, unfortunately, exactly where it's going to be posted. But I can be in communication with people here and let them know, and certainly maybe people are also welcome to email me if they're wanting to find out when make sure they get it. Which my email was on the very last slide, but so the slides will come out and my email address is on there.
So I'll send it out by email to the nurses.
Okay.
Great,
We
thank
can do
you.
health directors too.
Awesome. So thank you very much, Diane, for coming to the Learning Circle. I learned a lot, and I think I can think of its applications in lots of ways, in all kinds of work, and even though I don't do any clinical work whatsoever, but I work in the training of physicians, so it's really valuable work. Thank you all out there for listening and for attending. We've got a couple of, I also want to, before I go on to some of the next sessions, we've got lots of great sessions coming up, but I want to thank Steve and Jennifer and Al for their technical work at the FNHA, and also Catherine here at the Learning Circle. I want to thank Crystal. She's had to step out of the room. And thank you all for doing your good work. And just to let you know, the next sessions that are coming up, there's Wednesday, I guess that's tomorrow, there's one, a role model, Ashley McGuinness and Marlon Hall. That's the Youth Learning Circle. And that sounds really good. And then on Thursday from 10 to 11:30, it's health benefits. He's John Ma, the Vice President of the First Nations Health Authority, will talk about the health benefits program with the First Nations Health Authority. So that might be very interesting for some of you. And then there's more coming up around midwifery, Elder Jerry Ullman around decolonizing ourselves, and then a very big special event with Tunaha First Nations and Dr. Michael Yellowbird coming from California doing a session on neuro-decolonization, which is all about how stress and trauma affect our brain and behavior and things that we can do to change the way that we live our lives. So all very exciting. So thank you very much. I hope you have a great day.
Thanks, everybody. They're still there.